I can see Juan is all ready and lined up. He's got his talk, and looking forward to hearing from him. So Juan, this is Ashish. With me is Sushil. I have Ramesh Kagobari from West Virginia here, and we have a great group of anticipated audience wanting to hear the future of the mitral and tricuspid space.
Hey guys, first of all, thank you for the invitation. I really apologize. I couldn't make it in person. Do you guys see my slides?
We can see them, and you look a little better. I hope you're feeling better, and thank you for doing this, even though you're still recovering.
Look, it is honestly a little bit frustrated because I was really looking forward to going there in person and being with all of you guys. So my assignment for today is to summarize the current status of transcatheter mitral and tricuspid valve replacement. So what I'm going to do is I'm going to talk about the basic aspects of the field and describe a little bit the challenges and opportunities that we have today. Let's start with mitral valve replacement. I wanna start this talk by saying that the standard of care of mitral regurgitation is surgery. And I think this is actually important because besides MitraClip, all technologies under development right now are experimental. I think this is a paper I always like to present because it highlights, I really think, what is an accurate representation of what happens, at least in the US, and is coming from Cleveland Clinic, and is actually comparing the demographic characteristics of patients undergoing repair versus replacement. And you actually see that there is a certain level of selection bias, as patients undergoing replacement are commonly actually women, are actually older, and more commonly patients going to repair are patients with mitral valve prolapse, and in replacement, actually patients with mitral valve calcification or actually complex bileaflet mitral valve prolapse. Also, there is highly dependence on surgical skills, and according to the surgeon and actually the level of the skills of the surgeon, also the patients undergo replacement or repair. So even though surgery is the standard of care of mitral regurgitation, there is an important selection bias towards repair, and patient selection is influenced by patients' demographics, valve anatomy, comorbid conditions, and surgical expertise. One important thing to talk about is that the patients that actually we see in the real world are not necessarily good surgical candidates. And there has been right now a lot of discussion about a new definition of valve disease that is now called mitral valve dysfunction in patients with annular calcification. So it's actually a more generic term in patients essentially that presents with MAC. As you know, MAC has a very high prevalence in the general population, happens in elderly women, predominantly patients with chronic disease, with aortic stenosis. They're typically associated with small annular size, have actually extension into the leaflets, and presents an anatomy that is not favorable for a TEER. And these patients are typically rejected from surgery, and there is not a lot of data about these patients. And this is actually a high-risk population that represents a big opportunity for catheter-based mitral innovation. One of the things that actually we know is mitral regurgitation is associated with very bad outcomes. And this is another paper that is very interesting to read because essentially shows the natural history of mitral regurgitation in patients that are actually left alone. Very interesting to see most of these patients were functional MRs versus actually DMRs. As you can see in this cohort of patients of approximately 1,000 patients, 84% of the patients with DMR actually had surgery, 16% were left alone. In the FMR group, actually, predominantly, most of the patients were essentially left alone, which again is also a trend and an opportunity in the real world. You see the ejection fractions were different in patients with DMR, were higher compared to actually FMR. And you see that when these patients are left alone, the mortality actually is 50% at 5 years, and the percentage of rehospitalization over time continues to increase, virtually having almost all the patients rehospitalized at 5 years. MitraClip is the only catheter-based solution that we have right now approved for the treatment of mitral regurgitation. And there is no question that as the experience actually improves and the technology improves and training actually improves, the outcomes of the operators actually have continued to increase. And right now, in a good hands and in the right anatomy, the percentage of success in the right hands again is actually very high. Some people actually say it's close to 90 to 95%. But TEER has also important limitations. It's a procedure that is standardizable, but not necessarily reproducible. It's a procedure that is very simple to perform, having actually almost 100% implantation rate, but is highly dependent on the volume and experience of the operator. And the percentage of residual moderate to severe MR, again, depends on how well trained the operator is, the volume of actually the site, and actually other important associated factors, such as the availability of imaging. And the TEER performance in complex anatomy is a balance in acts in low volume centers in which, operators are more conservative. There's no question that actually MitraClip or TEER in general has a very excellent safety profile. In high volume centers, it's got a high excellent efficacy profile because the operators are more aggressive and actually more comfortable doing this. But this is actually the balance of actually leaving residual MR alone in the centers that are actually more conservative versus mitral stenosis in the ones that actually are more aggressive. So the future of TEER and other catheter-based repair therapies, highly depends on imaging-based prediction models of technical success, device evolution to allow the use in broader anatomical variations, and actually being able to reverse the procedure. And right now, there are multiple technology, including clip removal, to be able to allow the patient to be treated with something else in the future. The reality is, not all the patients in the real world can be treated with MitraClip or surgery. And we have a big proportion of patients in which the anatomies are not ideal, in which mitral calcification extends into the leaflets, and the patient doesn't have a good anatomical substrate to be, treated with mitral TEER. And this is actually perhaps the biggest value proposition of TMVR, because in a way, it's easy to actually implant, is agnostic to the etiology of MR. It doesn't really matter what the etiology is. Actually induces a reliable elimination of MR, and also ends up with a less recurrence of MR. The question is, what are the challenges of actually essentially do what the surgeons do and being reliable, reproducible, and actually safe as MitraClip is? This is an example of the potential impact this technology can have in the real population. This is a first-in-human study that I had the opportunity to be part of with Torsten Wahl and actually Thomas Moudin in Lille. You actually see this patient, the anatomy of this patient is not really purely MR, it's actually mixed etiology with a significant component of actually also stenosis with nodules actually on the leaflets. It's a patient in the 80s, was the first procedure ever. You see the surgical cut down and the minimal invasiveness of the procedure, despite the fact the cut down was surgical. And you actually see in a simple procedure crossing the septum and essentially deploying the device. This particular device that deploys in an Amplatzer-like form in a very simple single-step procedure. You see the valve being deployed here, and you see the final result, beautiful result in a very complex patient with a complete resolution of MR, MS in a procedure that was done in less than an hour. You see the recovery of the patient. In 24 hours, patient was walking around, moving around. This is the CT at 2 weeks, and the patient is being alive and doing well for 5 years. So you see the potential impact that these technologies can have, not only on the peri-procedural complication rates, but actually also at long-term follow-up if the patient is properly selected. Right now, we have 3 randomized studies in the US, including different technologies to treat percutaneously mitral regurgitation, and including actually also MAC. We have the Apollo trial that is including patients using the Intrepid valve from Medtronic, Summit trial using the transapical tendai, and Encircle that is a 2-step approach using a cinch around the annulus. Severe MAC patients actually are now included in all these randomized studies that were initially excluded from all TMVR trials. And we're not only now subsequently included, but became one of the fastest patient populations to enroll in all these trials. The technologies continue to evolve, and right now you see important improvements that I really think are going to be able to expand the patient population that we're going to treat, and hopefully is going to improve the enrollment rates. You see the new generation of Intrepid, for example, that has been able to reduce the size to 29 French and add additional sizes like this one of 54 millimeters, allowing the treatment of larger annuli, which is an important characteristic in patients with dilated ventricles. You also see significant technological improvements. This is the new High Life frame that has an open frame design, allowing the treatment of patients with potential for LVOT obstruction. The Alta valve design that is a supraannular design that essentially completely avoids the LVOT, allowing the treatment of very high-risk patients. Of the InnoValve that it has a similar kind of approach of sparing the LVOT by wrapping around the leaflets and leaving the LVOT completely open. So the technology continues to evolve, and the new generation of technologies will allow the treatment of more complex patients in the future. But what has been actually the biggest issue of TMVR, that the limited applicability of the current designs has not been applicable to the real world anatomy. And we actually ended up with high rejection rates. All technologies started with some philosophical designs and principles according to what they believed was the right technological attributes. The reality is, in the real world, it was a little bit unexpected to see the large amount of anatomical variations that actually are seen in humans. Not only from limitations on the septum because the septal height that is needed, but actually things that were unexpected before, such as like significant septal bulges, distribution of MAC that was very heterogeneous, subannular anatomical developmental abnormalities, and actually also device interactions such as AVR and actually TAVR. So the TMVR designs, right now have limited ability to cover absolutely all architectural variations seen in MR patients. And unlike TAVR, the development of a universal device tool, that one design is going to pretty much fits all, may be a little bit challenging. I really think that is getting better, and I think the percentage of anatomies that will be covered by designs will increase, but it's not going to be like TAVR that pretty much a single device could essentially treat all potential device variations. The main reasons for exclusions in actually trials is being the inability to have all sizes, either on the high side or on the low side, approximately 50% of the cases. And LVOT obstruction actually counts for approximately 25 to 35% of the cases. And this is a very complex actually problem because it not only depends on the anatomical variations and actually also device design, but also depends a lot on a lot of functionality of the survival apparatus. So it's actually a very complex problem that may not be completely solved by improved valve frame design and may need some ancillary tools to improve the eligibility of patients for TMVR in the future. MAC is no longer a problem, and most of the devices are now comfortable, or companies are comfortable treating actually MAC, and transeptal delivery is improving as the technologies continue to evolve. I strongly believe the next generation technologies will help the TMVR field to move forward. And I believe that the evolution of the transeptal TMVR delivery systems is improving significantly to the point that the percentage of rejection rates, are going to decrease in the future. We already have multiple valve sizes and design configurations that we didn't have before, so expansion of population will be possible. We already have technological alternatives to prevent LVOT obstruction with actually leaflet modification technologies that will allow us to treat more patients. And now we have a broader experience in real-world anatomies, including MAC. I think it's important that we start defining the target population and predictor of outcomes that are going to allow us to essentially treat the right patient and achieve the right outcomes. So moving actually shortly on tricuspid, one of the things that essentially happened is the large devices we ended up with and the anatomical issues actually seen in tricuspid regurgitation allowed the fast adoption of mitral devices to be used on the tricuspid space. So you can actually see the anatomical abnormalities on the tricuspid essentially are very good characteristics to be treated with large devices as the ones, developed for mitral regurgitation. Also, the field moved very quickly because we already had devices on the size and in the configuration that could be used on the tricuspid space. And also there was a market opportunity and also technical satisfaction. These devices are easy of use, actually have less imaging requirements that the tier on the right side, has very satisfying technical results, and actually relatively lower bar for clinical trials. So no question the tricuspid field has moved actually faster than the mitral field with these particular devices. One actually thing also to take into consideration is that TR is primarily caused by ventricular distortion resulting in multiple structural abnormalities that essentially happen over time. And tricuspid replacement is well suited to provide superior technical results as it addresses all anatomical abnormalities present in severe TR patients. With other repair technologies, you're only actually targeting one disease state. That's why the technical results are actually difficult to improve. I think actually the best evidence that we have right now for tricuspid replacement comes from this randomized study led by actually Dr. Kodali. The results actually are very well known and presented multiple times. And it's actually interesting to see that we start actually seeing a glimpse of what the challenges are on the tricuspid space, on the replacement space. You see severe bleeding in this cohort of patients was actually seen approximately a quarter of the patients. And actually 11% of the patients developed new conduction disturbances requiring permanent pacemaker implantation. And we started actually to see what the potential issues with replacement could potentially be. No question that the abolition of TR is significant. No question that actually the improvement in symptoms and functional status are significant. The question is, what do we need to do to improve the outcomes of tricuspid replacement? And I think it has to do with two main issues. One is patient selection again. It is actually now better understood that the ejection fraction and myocardial performance in this patient is extremely important. And actually having a more comprehensive evaluation of which is the patient that is going to improve is actually very important, especially in the setting of pulmonary hypertension and right ventricular function. And the second important thing is actually leaflet degeneration and actually thrombogenicity. So I am actually sure if all these things are actually properly addressed in the future, patient selection is properly achieved, and actually in a way, the thrombogenicity issue / bleeding, can be improved. This can actually be an important therapy in these patients that actually have limited options at the present time. So in conclusion, catheter-based cardiovascular intervention has evolved into distinct subspecialties in advanced coronary, endovascular, and structural heart disease. The success of the interventional field has been based on the development of new technical skills, evolution of the heart team, and commitment to research and training. The structural heart field provides a similar substrate for growth, especially actually on the mitral and tricuspid space. One important thing is heart failure is the epicenter of cardiovascular medicine. And one of the things that is important is that the new development of a structural heart disease intervention can actually have a phenomenal impact in heart failure and the treatment of patients that right now, are suffering because have very limited options to treat these important structural heart conditions. So thank you very much for your attention, and I'm open for questions, and I really hope to be able to join you guys in the near future.
Thank you, Juan. That was a great talk. I don't know if there are any questions, but part of this, the mitral space, I mean, you've been instrumental, involved early on. 10 years ago, we thought there'd be a TMVR device available within several years. You're still very optimistic, and you highlight the reasons why. But one of the challenges, and I'd like to get your perspective, is what is the regulatory pathway for approval? What is the comparator device? With MitraClip being so ubiquitous and some of the is it a fair comparison, MitraClip versus replacement? And what do you see as a regulatory pathway? And if you were in charge, how would you sort of approach this?
Yeah. So Sushil, one of the things is, as you know, the mitral field is a very complex field, and it was a very ambitious process from the very beginning. I mean, to be able to navigate a valve from the right to the left that is actually big and has all these mechanical characteristics and being able to implant it percutaneously. I mean, you remember before the field started, it was actually thought to be near impossible. To be perfectly honest, at the very beginning, we didn't even know if we were going to be able to do that. I think the field made a lot of mistakes in terms of the technological assumptions. That actually led to slower adoption because the patients that actually are in need are not the patients that we were treating or we are treating right now. And the technological needs involving actually sizes and design characteristics were not available to treat those patients. I think the field started to understand what the technical needs are, what the design requirements are. And I think the second generation of devices are going to allow the treatment of a higher number of patients. And I think the field is going to move forward actually faster. Now, the regulatory pathway, as you know, is not as easy as it was for TAVR. And I'm saying easier because TAVR, the only real competitor that they had was actually surgery. Mitral has, TEER and actually also surgery. So it's essentially occupying an important space in the field. But if you ask me if it actually was me, I would target these patients with mitral valve dysfunction and MAC. And essentially what I would do is use that group as the entry point for the regulatory pathway. And then from that point forward, start expanding the market if actually possible. The question is whether you randomize, against medical therapy, which, we can talk about the pros and the cons, or if you actually go into a less compromised population and randomize against MitraClip. I would personally believe that this technology, at least as it is right now, is better suited for cases in which MitraClip is controversial or high risk. And what I would actually do is try to randomize against medical therapy, at least at the beginning, and then try to expand the patient population into CLIP population as a second step.
That's a thoughtful answer, Juan. Appreciate it. If there are no other questions from the audience, I think we'll...
One small comment, sir.
Yeah.
I think treating mitral valve is not as smooth as aortic valve, because here we are just not talking about the mitral valve itself. We are talking about a complex, which actually involves treating the annular function, the chordae, the leaflets, papillary muscles, the ventricle, and the left atria. So that's a new thought which is coming in. We need to consider that. And that's the reason why we are lagging behind the aortic valve.
Correct, 100%. Juan, do you agree with that? It's a heterogeneous,
Completely agree.
heterogeneous disease and different populations, so not one size fits all.
Completely agree.
All right, my friend, have a great rest of the
Right.
morning. Thank you for your time. Appreciate it.
Joy.
Thank you.
Thank you. Bye.